Greetings to viewers via Zoom and to our YouTube streaming audience. We have participants joining today from around the world, from the US to India, a truly global audience. So welcome to this, the first installment of our CDO seminar series in partnership between Leap Beyond and Nordic AI. In this series, we'll be choosing from a list of burning topics about data in 2020 and the pivotal role that data currently plays in society. Each seminar will invite a new panel of 4 C-level experts from startups and established global entities to ask and answer tough questions. We have some questions to get things started. However, this is also interactive. If you're joining from Zoom, you'll notice the Q&A tab where you can ask and vote on questions for our panel today. My name is Rob. I'll be the moderator for the session today. Today's topic holds a particular personal interest and passion for me. Honestly, as someone who's been exposed quite recently to multiple facets of the healthcare system, and I'm really excited to be here today together with this inspiring panel. A warm welcome with thanks to our panelists. We'll kick off with a very short round to introduce the panel to the audience. So how about Egge, why don't you kick us off? Tell us a little bit about yourself and your role in data in healthcare.
Hi Rob, thanks for having me. My name is Egge van der Poel. I'm a clinical data scientist, whatever that may be, but my aim and my passion is to make sure that patients and caregivers have better access to information to support their decisions. I have a background in elementary particle physics. I've seen what's possible if humankind collaborates on a large goal, let's say the moonshot. We had the Higgs particle as our moonshot, and we collaborate with every nationality around the world, and we share data and we analyze data. And in healthcare, we're not there yet. And I hope to make sure that we go towards the transition where we can start sharing data more structurally, and we start harnessing information from it. And in that view, start learning from every patient from the past to make it better for the next patient.
Awesome, thanks Egge. On to Bert.
Thank you, Rob. Thank you for having me. Very exciting to see different disciplines coming together. My name is Bert Hartog. I'm working at Janssen Pharmaceuticals in the clinical innovation space. And my objective is to see how we can improve the experience for people participating in clinical research. Clinical research is super important to bring new medications to market, involves a lot of people and a lot of clinical trials, and the experience can be quite intense and quite burdensome. We try to improve that, where we look at data and how data can help make better assessments and allow people to have a better experience. Data coming from technologies, data coming from devices, data coming from existing repositories, really a plethora of data sources. And I'm looking forward to discuss with the panel what we can learn from different industries and different disciplines.
Thanks, Bert. Lovely to have you here today. André, tell us a little bit about yourself.
Hello, I'm André Hermsen. I'm living in Holland for all the viewers all over the world. I'm working with NAST, Medical Service Center. NAST is next to you, and next to you we are, but on a distance. We are a virtual caregiver, and we only give care on a distance. My role is innovation manager. I'm thinking, how can you change the processes of caregiving when you have digital possibilities in the world today? And my drive is to change the world in healthcare so we don't have a problem later on when we don't have enough people to give care to the people who need it. And Corona was a situation where you can see what is happening when that, something is happening like that. And I hope I can have a little bit help to change the world to a better place and a healthier place.
Thanks, André, very inspiring. And of course, Levi, tell us a bit about yourself.
Yeah, thanks Rob, and thanks for having me first of all. My name is Levie Hofstee, and I'm one of the founders of Neurocast. Been an entrepreneur for a very long time, background in marketing, data and business innovation. I really love translating innovative technology into concrete business opportunities. And besides being responsible for product strategy and innovation at our company, I teach digital innovation in an MBA program for healthcare professionals. And with our company, we developed a truly passive patient monitoring platform. We believe that it is very necessary because we if you want to come up with new medications and treatments for all those people suffering from chronic and deadly diseases, you have to be able to measure well, and especially mental, physical, and emotional performance. But the traditional tools, in our opinion, are failing. So that is a thing that we would like to address. Excellent,
Levi. So we now have about 30 people watching us. Greetings, everybody. Welcome again. And we're going to jump straight into the questions part of the talk, which will take us like the next 50 minutes or so. So first of all, guys, I mean, it's so inspiring to have everybody here today, and I'd love to hear about what inspires you. So I'd love to hear what projects have you seen that use data in healthcare that are that are inspiring, that are really making the most impact driven towards data-driven healthcare. So if I can throw that first over to Bert. You've seen a lot in pharma, Bert, and across the board. Tell us about what's going on.
Thank you, Rob. Yeah, very happy to speak to this. This is an area I'm quite passionate about and have some strong feelings, because data, there's an abundance of data in healthcare. Data volumes are not the issue. There's plenty data. The issue is that it all looks different. It all sits in different places. It is very inaccessible. And when it is accessible, you often find that it sits in silos. A hospital may have an electronic health record system where all the data from all the patients in that hospital can be accessed. Wonderful, very nice, you would think. But for research, you want to pool hospitals. You want to see how patients in one hospital compare to the same patient in a different hospital. And guess what? That's where you find that the data is created using different standards. So a patient with certain characteristics in one hospital, that same patient looking at the data looks different in a different hospital. So when you start comparing between hospitals, it's very, very difficult. That is in a country. In a region like Europe, it's even worse because you've got more hospitals and more variations of how data is captured and how data is maintained. Two projects I've seen, one succeeded from the first one, are sponsored by European Commission funding. There's one European Medical Information Framework project, EMIF for short. That's where we started talking about how can we harmonize the way data is captured, the way data is labeled, and how can we build a federated network where privacy can be maintained, the data can be aggregated, the level up from the hospitals. So you can start aggregating these data sets in a virtual manner for higher level analytics. And the succession project is called EDEN, the European Health Data Network, also funded from the European Commission. And that is, these projects are combinations of pharma, academia, and tech companies. EDEN is demonstrating day in, day out, what insights you can generate from these pooled data sets. In a matter of days, they can run queries on these aggregated data sets with hundreds of millions of patients represented to get these very deep insights that help define new treatment options or help define clinical decision-making at the level of individual patients. So these are super inspiring projects, not easy, not cheap, but really the way forward to get access to this data that's abundant and to be able to analyze the data to generate these insights. Two examples.
What inspires you the most about these specific projects, Bert? What do you think these specific things in terms of patient outcomes or experience? What is the biggest thing that an individual would see from these projects?
The biggest benefit is that patients can take advantage from what has been learned already. Patients in the Netherlands can benefit from what happened to similar patients in Sweden because the data tells a story. So as a new patient, all that history from patients like you is accessible for analysis and evaluation. So these insights can be used for your treatment. So you are benefiting from history rather than being a new patient that starts at ground zero. You start with all that history available and all these insights available to your doctor to discuss and see what's the best treatment option for you.
Great, thanks, thanks, Bert. Well, let's see. Let's ask the kind of the end point of that question. Egge, you're physically in a hospital a lot of the time. You are trying to make benefit of these systems that are there. What are the things that most inspire you about what's going on, or have you seen the output of these larger initiatives affecting you and the patients around you?
Thanks. I was very fascinated by what Bert was saying. I think. Of course, the harmonization is essential to do this large-scale data analytics. Let's call it the old-fashioned word big data. But I'm also very passionate about combining both data and stories. I believe there's a lot of stories in healthcare where we can learn from, and I see both sources of information as something we can learn from. So I'm really fascinated by what Bert was saying, but in my practice in the hospital, in the Erasmus Medical Center in Rotterdam, I'm very much addressing the individual needs on a different way. And let me sketch that. I think there's a lot of talk in healthcare about what's being called value-based healthcare. That's the outcome-driven healthcare, in the sense that we're not looking at a disease, we're looking at a person with a disease. And we all know examples, or we are the examples where we have experienced that it can be more patient-centered, or more attention can be, let's say, aimed towards an individual. And what inspires me is that we can have instruments like data, but also like other instruments, where we can better assess how someone is doing outside the walls of the hospital. And outcome-driven research or value-based healthcare is one instrument where we ask patients to fill in questionnaires. This is obtrusive, so to say, so people really have to actively do something, but it's already very valuable if we start seeing that people, after having surgery in our department, are afraid to go outside because they have, let's say, scars in their neck, or they have trouble speaking or trouble swallowing. They don't dare to go outside and eat or something like that. That's very impactful for someone's life. And then you can say, okay, the cancer is gone, but yeah, what's left of the life people were living? And I think one of the things that inspire me most is that we're trying to find the right balance for every individual to have a discussion about, are you looking to, let's say, fight the disease, or stay living a life that's worthy of your energy to spend on it? And for me, working in Erasmus Medical Center, using the patient-reported outcomes on a day-to-day basis when the patient comes into the consulting room with the doctor, that's, for me, is very rewarding work to have. It's not rocket science. It's nothing like we did, Rob, at CERN, but it's just making sure that people that are very vulnerable and are sick have answers to very basic questions like, how am I doing compared to others, and what can I expect for the future? And by using data from these patient-reported outcomes, we can already, let's say, benchmark someone to the people we've seen in the past. And it's in one way fascinating that this can be already very valuable for a patient. And it's very hopeful that caregivers are now opening up their mind that the hospital data alone cannot answer these questions. So to just add to what Bert was saying, you can combine data from multiple hospitals to do this big data analytics, but I think it's also very valuable to start adding the personal data and make sure that you have a real good image of how someone is doing actually.
Well, this speaks to me, Egge, so much on precision medicine and personalized medicine. Very, very important. You know, I as a patient myself, I do often feel like there's been a little bit of a move away from a kind of personalized healthcare situation. And obviously there's the Hippocratic idea that treat the patient, not the disease, right? Which modern medicine seems to have moved away from that quite a bit. But then coming to something more personalized, where you try and understand the person, you try and understand them over a long period of time. This is something that I know that Levie is incredibly passionate about doing, particularly for long-term neurological degenerative conditions. So Levie, tell us about that. What inspires you in that space? What things have you seen, and what are you doing already there?
Well, especially if I look at our own work and relating to what Egge said, if you want to know how a patient is doing, so on a very personal level, you have very few options. Basically, you can ask them, or you can do a test, or a combination of both, basically. Or put them in an MRI for something. And I think that we need to do better because it's not only, in my opinion, comparing one person to the other, but also comparing you against you, because there are multiple Robs, for instance, because even though physically you might not be doing so well, you do have a smile on your face because you are very enthusiastic about things. So the actual bandwidth a person is moving in can differ from person to person, and even from day to day, and even from times during that day. So we are really passionate about figuring that out, and knowing, like, in an unobtrusive manner and real time, how a person is doing. And if we can tell how a person is doing on a very personal level, with the same data, we can make all different setups. So you can compare a person with a person, or a person with a group, or a group with a group. But the tricky bit is that you have to validate the things that you are doing. So the innovative stuff that you are doing, that you have to validate it against old, I don't want to offend anybody, but let's say gold standards, which rely on different data sets or different inputs.
Which is very, very intriguing to me. So as a particle physicist, you know, we work in a realm of where you have all these uncertainties, some of those that you know and some that you don't know. Systematic uncertainties are ones related to the methodology you're using or the equipment you're using, which add in potentially a large range of within which you can say, well, you know, this number is 1 plus or minus 2, and you want to make these more precise over time. But as you're building more detectors as a particle physicist, you have the theory about where this should be. You know what you're trying to get to, and it's relatively a lot more easier than trying to build those things for patients. But these kind of scatter plots of one measurement technique against another one, they're always not going to fall in a straight line. The statistical variation is going to be there. It's very hard to convince people, though, I find, about statistics. Say, well, just because my measurement doesn't agree with yours doesn't mean you're wrong, doesn't mean I'm wrong. We have different precisions. We're measuring slightly different things. And in terms of that, so measuring slightly different things, and also what you're mentioning, Levie, comes a lot onto healthcare at a distance, gathering more data, using that to compare yourself to yourself and to others. And Andre's here today to talk to us a bit about digital care and what that means in Netherlands. So if I can rotate this a little bit for you, Andre, this question, not just about the inspiration, but also with the type of things Levie wants to do right now, it seems to me that those technologies have existed for 20 years. So why is it, do you think, Andre, that we don't already have this? Why didn't we have this capability 20 years ago?
That's a good question. I think that's something what's special in healthcare. It doesn't change very quick. We are used to do things that we do a lot of time, and we do that tomorrow again. And when something changed, like Corona, then you see everyone's doing something new, but the new was 20 years already there, but they do it now. But now Corona is a little bit going down, and you see that they are going to do what they did before. So the change is very difficult. And I think the change in the healthcare is difficult, not of course the people, cost the system, cost the finance, cost the law, cost the quality. It's more than only one of these things, and that makes it difficult. I want to react on my other panel members. I like it what you said, and one of my drive I have is we have to do more together, and I hear it now again. I will tell you what we are doing by NAST. But by NAST, is, for one of the projects why we use digitalization is that we chronic disease people that have heart failure or COPD, not coming back to the hospital, but they are at home, and we monitor them when it's necessary, and we can act with them, interact with them when it's necessary. And the idea behind it is that you don't want to be a patient when you have that, you want to be a people, and you want to have joy in your life as much as possible. And when you can try not to get iller, or not to get have problems with your illness, or zoals you did, come out of the hospital because you want that, that is better to do. So we are trying to change that, and we did that with the hospital, with Slingeland Ziekenhuis and Doetinchem, to try that, and we now know we know it's working. It's working for the patients, it's working for the system. And now I want to do the next step, and that's some data is coming. We can learn a lot of the data we have to predict when it's going to go wrong. How we are react in healthcare, but we have to be proactive. And proactive you can be if you know something before it's happening. And when we can do that, then I think we make a lot of difference in how is healthcare now today for the future. And that's my drive. And I think it's possible, but you need have a lot of experts to help to do that. And I think data is the base. And Rob, Bert, you're right, how I can get that data together. And Edge, yes, it's going to how can I live and not be ill, but how can we manage that together and make that more possible? I would like to do that.
Yeah, sounds great. And since you mentioned Bert, let's ask a similar question to Bert. So Bert, all these data sets coming together, as you mentioned, in different initiatives, but still, all these initiatives are very long term. So, you know, what did stop us from starting this 20 years ago? What's the pace of change now? Are we able to adopt these things quickly? You see across a large aspect of the pharma community here. So let us know from that 30,000 feet view.
Yeah.
What are things like?
Absolutely. And let me use the earlier example from Levie and André. Levie explained how passive monitoring can really add context to the story that a doctor can see. And André talks about predictive analytics, where you can tell somebody like, hey, something is about to happen in the near future, or maybe the longer term. There is one step in between, and that is being able to analyze the data real time, semi-real time, depends who you're talking to. When you talk to technologists, it's semi-real time. When you talk to patients, it's real time. Meaning there's data being collected and you want to see what the circumstances are at that point in time. Event-driven data collection. You see something happening because a patient is wearing a sensor, data is coming in, something's happening that doesn't seem to make sense. That may kick in predictive analytics, where you can say, well, in a week's time, in 2 weeks' time, but maybe before you do that, you want to know what's happening. Are you running a marathon? Are your vital signs off because you are very active? Are you maybe sleeping during the day, which is a little bit unusual because you always sleep at night? So some of these signals need to be interpreted in the context where the data is generated. And if you can collect data, passive or even active, but outside the clinic, and you can react to the data by asking questions to understand the context, then you can really start tailoring to the individual and the individual circumstances. And that is something, and to answer your question, Rob, that is something that we can start doing already now. Levie has the technology to do that right now. André can probably already make that fit in his processes to prepare and front load these predictive analytics. So when we start doing this, all these little experiments at individual patients, individual hospitals, we can start connecting local initiatives with these higher level big data sets. And then when the two come together, you can really make that change happen. When you wait for the 30,000 feet big projects to land, that will take a long time. But when you supplement with this bottom-up approach from individual doctors, individual patients, you can really accelerate the implementation of what works and what can become a best practice.
Really speaks to me, working across the board and connecting these different groups together. Levie.
Yeah, Bert, I wanted to react on what you said, because I agree, but I do think that we are just starting to comprehend what data-driven healthcare could mean or could be. And that we are living in a world that is becoming completely digital and not merely one that is digitizing. And I think that is a distinct difference. And the latter implies that translation of current approaches to digital technologies while going digital requires a complete rethink of the status quo. And that with all the stakeholders involved, that we need to reimagine like a value change and drive innovation before deploying innovative digital technologies. How do you look at that, Bert?
That is music to my ears, Levie, because that's what I do day in, day out. When I mentioned we are trying to find out how we can give people who participate in research a better experience, that is really aimed to make trials and clinical research more attractive. So more people will feel more comfortable participating in research, which contributes to bringing these new treatment options to the market. Part of finding out how we can do this different is really to set transformational goals. Incremental change only gets you so far. What you described, this digital world, that is a transformation from where we are today and where we came from. So we ideate completely new ways of working, and I'll give you an example. Voice technology is becoming quite common. Everybody has a smartphone with a voice-enabled assistant on that smartphone. And I'm sure when I say the word, phones will start reacting. Siri, Alexa, you've all got your own examples. When you're smart, you change that word because you don't want that wake-up word that when you're in a group of people, somebody utters and your phone starts responding. That would be embarrassing. But this voice-enabled technology, the last 2-3 years, has become so powerful that we are now looking at ways to include that in our clinical research, to generate data where the voice tech can ask questions to a patient wherever the patient is, and the answers will help understand what's happening, can be survey questions, etc. Some of these patient-reported outcomes that Egge was referring to, that you can collect wherever people may be, whenever. But also to use that voice technology as a channel to communicate back to patients and to help them live with their disease. For clinical research, we call it a concierge concept, where we tell people your next study visit is that date. This is what you need to do to prepare. This is what you need to do tomorrow for your medication. So it's almost like a personal friend who guides you through the research experience, but all enabled by voice technology that can be delivered through an app on your phone or a smart speaker or whichever channel you have access to, but trying to personalize this virtual assistant in a research setting in a bidirectional way to offer information, intelligent information, and to retrieve information that feeds your database. So as one example, to move into this digital world, where if this works at a small scale, we start looking at scale up and trying to replicate multifold to go across countries, ultimately across the world, etc.
Leads me to two very obvious follow-on questions, but thanks for that. I just want to say we're about halfway through the session now. For those people who joined late on Zoom or on YouTube, hello, welcome. If you're on Zoom, you'll notice we do have a Q&A tab. If you have any questions you'd like to pose to this panel, please throw them in the Q&A. Leonard in the background is reading them all, and will let me know if there are things to throw to the panels. So please go ahead and do that. But what you were saying, I mean, about collecting this data over long periods of time, collecting it from voice data. Obviously, everybody who had a Google in their house or an Alexa in their house was very, very concerned when they discovered that actually AWS or Amazon was taking a lot of the background noise data from their house in order to do to improve how good Alexa is at listening, but without asking permission for that in advance. So people get quite sensitive, strangely, when it comes to this, and people are also very sensitive about healthcare data. And so the question I'd like to pose to Egge, because I know that he works a lot with these kind of regulatory bodies and and people in these positions, is what does the public think right now? What's the public kind of the heartbeat or the zeitgeist of the public towards more use of data in healthcare, of this passive data or data that's collected all the time? Like, what are people thinking? What's the underlying current there?
Well, thanks for that question. It's a hard question, because now we enter the fluffy stuff, so to say. I mean, it's easy to talk about technology and say we have a solution for that, but when you try to implement it, you have to deal with people and their opinions and their feelings, and then it starts getting messy for us techie guys and girls. But this is a crucial part to me, and I want to come back a little bit to the questions raised before, because you asked the question, why haven't we implemented the technologies that are abundant? I think it all comes down to what André so very politely described as the healthcare not being the most fast adoptive sector, so to say. And to slightly illustrate that, in the Dutch healthcare system, we are very enthusiastic about something that has been published 2 years ago that's talking about the right care at the right place, so to say. So you get the right care at the right place. But from a consumer perspective, we're used to getting the right information at the right time for the right person via all the channels that are available. So why haven't we adopted this technology? Well, there's a lot of conservatism in the organizations, and they talk about privacy, and it's hard and it's techy, but it's not about the tech stuff. We can manage, let's say, full scale from the individual all the way to the 30,000 feet high data governance structures. We can do that. We can do that. So it's not about the tech stuff. It's about people are afraid to take that step. I mean, and I'm talking about individuals on top of organizations or regulatory bodies that are afraid to do that because of the public opinion. So my answer to your question previous, why haven't we adopted these technologies? I think the answer lies within, when do people stop putting up with this? When do people stop accepting that you always have to wait at the doctor, that you always have to answer questions about medication, that you always have to answer the same questions over and over again? And why do you have to take your own information from one place to the other? Why do we have to fax those things? It's suboptimal, so to say. And when are we as citizens fed up? I think we're getting there. It's growing. This discomfort is growing, and it helps to have visionaries like we have on the panel, like André, Levie, and Bert, that are describing what's possible and that are really creating small successes. And I'm hoping for the big breakthrough when we really start to have this, well, citizen science also, because Rob, if you would have your own data, you would do fantastic stuff with that. So I'm envisioning a future where we stop thinking about research and clinic. We just have healthcare, or even just well-being, and we collect information, we collect data, so data and stories, we collect information, those to have a context, and that's available via a very clear data governance ladder, so to say, and we can arrange this. It's just a matter of breaking through this conservative mindset.
And Egge, it's not really about the willingness of citizens, right? Because recent research shows that 80 or 85% of people are willing to share personal data so that healthcare providers can improve patient care. But I also think that we need to, or that the healthcare industry needs to stop presenting it as a binary decision, like you are sharing it or not, because that is not the thing, because it's not one big box. No. It's an array of little things where patients should be in charge of what, when, how, when, where, with whom, for how long, for what kind of project. but we are confusing patients. And the same was with the whole Corona app thing. The news was talking about, are you going to download or share your data in the Corona app? And nobody was discussing what are we actually going to share, with whom, for how long in a Corona app. So the public opinion already was tainted before it even had the chance to become a success.
Yeah, so there's a big, let's say, task for us all to not only talk to each other, but also to do public appearances and have people think about data literacy and so on. Because I think in the end, we need to really start thinking about data commons and that's kind of future images. And then exactly as you put very well, Levie, it's all about the context and the timeliness of the data sharing. And I think, I mean, when I started working in healthcare after working in science, and there was a lot of skeptic reactions about, data and the future of it and so on and so forth. And there were even people saying that if we start analyzing data and collecting data on a large scale, that we will kind of break down the solidarity in our healthcare system, break down solidarity in our society. I think if we have the right data governance structures and we ask the right questions towards patients about, do you allow your data to be used to make sure that we can address the question of the next patient better, you will get 100% response saying yes. So I think that if we have the right structures, it can improve solidarity and not break it down.
Andre, you get this real-time data from the people that you care for outside of the hospitals. Happens all the time. What I want to ask for you is how much do the people who receive those digital solutions love it? Right? How much are they like, wow, this is fantastic. I wish I had this 10 years ago. I want more digital stuff. Tell me about this.
I answer that. First of all thing is what's in it for me. We have to think about what is in it for the patient or in it for the civilian. Because if something is getting better, or I feel better, or I feel secure, or when I get a heart attack, I hope they have my data so they can help me in a good way. That's what you have to think about. So I change it. Yes, the people who are in the program by us has a need to be in the program, and they have value about it and to be in the program. There's no problem. When we ask them, what do you find about it? And what do you find about what we're doing for you? There's not a discussion, because when somebody don't want to do it, they go out of it. And that happens a few times. That's what you have to do. So if you want to share data or use data, explain, give the reason. And then I'm totally agree with Egge. Yeah, that's what you have to do, because if they know what's doing with it and what's in it for them, but also in it for somebody else, then it isn't somebody else will pick my data and do something with it what I don't know. That's the difference. So no, there's no problem, but be aware that you have, so everyone has to know what's in it for me, what's doing it for me, and then can make the choice. Also with the Corona app, if you know what it can do for you, then it's not a discussion why they took my data, then you know what they're doing for you with your data. That's a change.
Sounds really good. I mean, Egge was talking also about winning the hearts and minds of regulatory people and convincing them also that this is a positive move for society and something they should be doing.
But can I react on that?
Yeah.
I don't think that the patient and the people are the problem. No, they have a reason to give it. The problem is the one we give the medical, the professionals. What's in it then for them? When they can do caregiving by themselves, then they feel good, because that's what's the reason why they become professional. But when you said, okay, you don't give care, but you give him something that he can do by himself, I can't do anything anymore. That's a change we have to make also in schooling. We have to change it, that you are a good professional when you don't do something instead of that you're doing something. And there's a change of mindset, and we have time, we need time to do that.
I'm sorry, I hope I didn't phrase the patient as a problem. I see the patient as a solution.
No, I didn't say that. No.
Okay.
Yeah, you didn't at all, but I would say many people do think that's the problem. That's not the problem anymore.
Yeah, so what you mentioned is sort of an existential threat of the professional, right? Their autonomy is being, but Yeah, so I do believe, and that's why I'm working very hard on educational programs. I do believe we need to also get their data literacy up. We need to make sure that we talk the same language, also digitally wise. Then again, next to this, let's say, educational effort, I truly believe that there's a lot of interest and stakeholders that really, well, sometimes need their heads to be banged together to make the next step forward. And I'm very interested to learn from your experiences in that perspective, because, well, I've been banging my head a lot of the times, but I'm looking forward to learn how I can do this better.
I can do that better than you. But what I would say, I'm a professional by myself, huh? And I know it, because when I learned my profession, I learned what to do to help somebody. That's all the thing what I learned. And now I'm learning, what do I give somebody and don't help him, he can help himself, or it can help by an app or by the digital. It's a change. I think we are changing, and I think that the world is changing faster than the healthcare is doing now.
Yeah, and to reflect on that is I mean, we are based in the Netherlands, and we have this very rich country with well, top-notch healthcare system compared worldwide. These technologies that we're talking about, I suspect that they will be adopted quite easy in other parts of the world, right? Because if the ratio between a caregiver and the number of patients gets smaller, so more patients per one caregiver, then you will start needing technology much faster. What you described, André, in the beginning is we are getting less and less people to be interested in being a doctor, being a nurse, and so on and so forth. So we will have this problem along the road in the Netherlands, but along the road doesn't create urgency for the people to really act on. Well, in other parts of the world, well, it's a different ball game altogether. Okay, where do I have to immigrate? No, I'm joking.
So Alistair, in the UK, he works with lots of NHS specific centres and private practices, and also regulatory persons. He asks about. We get a lot of this siloed approach in everywhere I look in highly regulated sectors, in banks or whatever. When people collect data, they think of it as theirs. I mean, GDPR is around to tell you, no, it's not yours. It belongs to the subject about whom you collected that data. It doesn't belong to you. You just control it. That's not the same thing. But Alice is also asking, have you got counterexamples? Where is it working? Where are small people, small groups releasing their data in particular private practice? Perhaps Egge can come with some examples.
Well, I think the way to go forward is something that's been called the Go Fair initiative. So we have the findable, accessible, interoperable, and reusable acronym that's been positioned as a way forward, mostly for research, but now it's finding its way to practice. And I think if we start using this methodology or using this way of thinking in the current practice, then we have a very good chance of getting this data governance structure from the bottom up in a correct way, so that we can start harnessing the data and information in a more effective manner. And if you look at the Go Fair website, they have some examples of doing also in a COVID case some very interesting stuff. I do see that a lot of organizations that I've been talking to, when they talk about ownership and data ownership, they acknowledge the fact that it's hard to trust other parties with data. So they believe that they should be the herder of the data. And I think that's not the way forward. I think we really need some, well, Go Fair is a technology, so to say, but we need to start thinking about small regional data structures like data commons that we can install. And to be honest, I've seen a lot of inspiring thought experiments, but the truly practical implementation of this, well, I haven't seen a lot of it.
Levi, same question to you, sir.
Yeah, but Egge, don't you also think that the regulatory framework for this should change? Because if you look at the guidelines, then also for GDPR, one of the first questions is, who is the processor and
The
what is on the
controller,
other,
yeah, the control
and
of the process and the
control.
subject.
So it's a very binary decision, and we already in our own research projects are often having lengthy discussions like, are we the processor, or are we the controller, or vice versa, or are we both? So it's not, I think that it's often not one or the other, but that there is some middle ground in there, and that we, for instance, can put technology like blockchain in place to really say, okay, it's not ours. We are only here to enrich it. It's yours. And we can use it if you allow us. But
I agree there's room for improvement there. So the thing is, I don't know the legal terms in English very well, so I will just not try to mention a lot of those terms. But I like the way you think about, it's not black or white, it's not binary. A phrase that comes to mind with me is data stewardship. And I think data stewardship is a way of thinking that inspires me, and is a way that I can map on at least the Dutch healthcare system, where we have the patient's first point of contact or the citizen's first point of contact for care is the general practitioner. Well, from that point onwards, you can go to a hospital or another caregiver, but in the end, the general practitioner is sort of your main point of contact for the care that you're receiving elsewhere. And if you use that relation and also that trust relation as a base for GoFair principles and also for data stewardship, I can envision ways that we can map data stewardship on this already existing trust relationships to have technology help support decisions along the way.
It's a really interesting point. So from my position, I actually work with lots of other groups in highly regulated sectors, banks, insurance agencies, things like that, which are experiencing initially we're experiencing exactly the same type of confusion about GDPR. So, I mean, GDPR provides a structure and a nomenclature about how to work with data, but I know several where there are several groups which have dual controller contracts between both, dual processor contracts between both. GDPR is putting a focus on what is the purpose of what you're doing. That is the absolute top thing. And the more honest you can be about that purpose, the more upfront you can be about it, that's what enables you to then process the data going on, whether you're the controller, the processor, or whatever. Make sure everything is contractually there and sound in this linking chain, but what is the purpose? And that's what people forget. In a recent project at a bank, they were coming up with these purposes, which were, they're very long, very complicated ways of saying something like, we need to know your name because we need to send you letters addressed to your name. That's the purpose of us knowing your name. We don't need it for anything else. Otherwise, you're just a number in the system, right? That's the only reason we need your name. So identifying who you are is a purpose. And you can just tell people, look, the reason you're giving me your phone number and your address is because I'm legally required to identify who you are. I'm an insurance agent, so I must have this information. So that's why you're giving it to me. I'm not going to do anything else with it. But when you tell me about, how many car crashes you've had, I am definitely going to do something more with that. So the purpose of that is to make sure that everyone in our group is protected. It's all about protecting more people with the same insurance. And that's why we're doing that. So this is a very, very important thing. So switching over to purpose. And when you start telling people, like you were saying, Egge, like everyone here has been saying, when you start telling people, this is about using what happened to you to make the very next person that walks into that hospital have a better experience. This is what that's about. And that's the whole purpose of this. Will you let us use your data for that? Yes, multiple people are going to see it, but it's going to be anonymous, or it's going to be in your control who really sees it and who doesn't in this app or something like that. So this has been a rather a whirlwind tour of some of the topics. We're down to about 10 minutes left. I'll just shift gears into a couple of other places now. There's some, with the technology that's around there today, a couple of crazy ideas come to mind. So, for example, we spend a lot of time in society training doctors. What I was really interested in finding out is, do you think we could train an algorithm to behave similarly to a doctor? Could we send an algorithm to medical school? If we sent 5 data scientists instead of 1 doctor to medical school and asked them, hey, can you get an algorithm to pass medical exams? Could we do that now? Is that something we can do, do you think? How about Bert?
I would be inclined to say, of course we can. Because half of what doctors do is triage from symptom to diagnosis to treatment. Most of that is based on protocols. So yes, you can build an algorithm to do just that. Take these symptoms, get to a diagnosis, and pick from all these protocols. But I deliberately said half, because the other half is not so scientific. The other half is intuitive and personal and based on circumstances. So one way to make this work is to use the algorithm and allow doctors to make up that other half. So don't replace doctors with algorithms. That would be the worst thing to do. But help doctors by using this algorithm to give them pre-selected information, save them time, not having to go through all this detail and memorize all this detail. And in fact, we see some of this happening. There are examples where algorithms are used to allow doctors to see from all the treatment options available, which ones, 2, 3, 4, have the highest probability of success in that particular patient. So they don't have to memorize all these hundreds. They get this short selection and they choose based on circumstances and the individual unique characteristics of that patient. That is a huge quality improvement because the chances of picking the wrong treatment are much smaller because they start with a pre-selection. So that's where algorithms can make a real difference.
I like to react on that. I like it what you say, and I think you can start with this to change the schooling. Because if you look at the medical exam of this way, the first 6 years they are learning all kind of data, and then they starting with what I have to do with the data. If you can change them and learn them in a quick way, how do I use the technology, the algorithms, the help they can get from all the information, and start earlier. What do I with the information? How can I interact with the patient to do the right thing for him in a positive healthcare idea? Not treat cost to treat, but treat cost as something for the patient. That's something else, and that's very difficult to change that by a robot. Then I think you can have a lot of experience, and I think that the change of the world of healthcare is going quicker because we get other doctors, and an other doctor has learned to work another way, and those so adopt quicker. So I think, yes, what you say, I'm totally agree. We can go without the doctor. No, we never can, but the doctor has to be another person in what he does, and he changed from the knowledge from him to the interactive, the coaching, the talk about it, the positive life, and that sort of kind of things. Yeah.
There's a nice quote. Oh, sorry. There's a nice quote from 1968 that I use in presentations. It's about computers and doctors, because that was kind of when computers came into the consulting room. There's a nice quote that is still valid, I think. It says, any doctor who can be replaced by a computer deserves to be replaced by a computer.
Yeah, that's very nice. That's nice. Yeah, I'm through.
So we have another question from the chat. We only have a few minutes left, but I want to give a chance to get this one out there. So healthcare, especially in the Netherlands, KPIs, incentives, KPIs, do this thing, get this much money, hospitals, doctors, insurance agencies, everyone all up the chain. Is that really the thing to do? How when we innovate, how are we innovating to avoid just that cost reduction and instead innovating for patient outcomes? What's the way to do that? I'm looking for a volunteer to answer this very interesting question first.
I would like to just start with that and then give it to the next one. So I think this is a societal issue, right? I think it's about what do we value in our society, and is it only the financial value that we see as something that we can, let's say, define KPIs on, or do we accept other dimensions? So in healthcare, it's very explicit that we need multiple dimensions, but I think from a society broad perspective, we need to harness the fact that we have people providing care, people providing education, people providing for safety. And so one way or the other, at least in our Western society, the Dutch society, we are valuing other professions higher than these professions. And so we need to broaden our mindset as to what is of value to us, and not only on a financial dimension.
Yeah, and I think Egge, if my co-founder would be here, then he would say that KPIs are short for killers of potential innovation. We really have to look at what is indeed what we value differently, and not only about money and time, or but I really hope that in the future that we can separate the words health and care, because now we always say them in one go, but if we can start focusing on living in good health, that has nothing to do with care, because ideally you want to you don't even want to start labeling people as patients, and that is a totally different mindset that has to being accepted. And that also means that the traditional KPIs that are custom in healthcare, they don't work anymore.
Yeah, we need to get a little bit more sophisticated in this space. The technology is developing super fast, and the incentives are struggling to keep up with that pace. For example, in the last 6 months with this pandemic, it has taken a lot of time for doctors to actually be rewarded financially for these teleconsults, because that wasn't part of the system. And very often when there was a financial reimbursement for these teleconsultations, it was much lower than the same time spent with a patient in a clinic. Now think about it. Why would a doctor get, let's say, X for seeing a patient in a clinic for 8 minutes and get half of that when talking to a patient over the phone? That's the same time spent by the same doctor. So these incentives are not aligned. So we need to align these first, where the behavior we would like to see, patients spending more time outside the clinic, that should have no implications for the doctor. If anything, the doctor should get a reward for it, because if it's better for the patient, the doctor should be incentivized to do more of it. So this perverse reimbursement for clinic-based assessments needs to be reversed to really encourage these off-clinic based assessments. And the technology can enable it, but if the doctor doesn't get a reward, it's going to be a very hard sell to change the system.
Excellent, thanks. So only a very short amount of time left before we close the session. What I'd like to hear from each of you in just 1 or 2 words is, look, this is CDO Seminars 2020. What do you want to see in CDO Seminars 2040? What should we have done in the next 20 years? What does health look like? How different is it? What's the inspiring story you want to lead us into the future with this on? So how about André to kick us off?
That we talk about health and not over illness and sickness, and that we have a system that is providing health and give to everyone a good life. And a good life isn't without an illness, but we can give so much that you can be healthy in your mind and healthy in your life. So I hope we discuss that part of it.
Levi.
Yeah, amen to that.
Awesome. Bert.
I would like us to talk about how a personal data cloud that people carry with them all the time is continuously updated with new information, both health related, disease related, but also environmental and context related, how that contributes to the good of the population people are part of, or the good of humanity if you take it to a global scale. So how all these local efforts, individual efforts really contribute to everyone getting better as a result of it.
Awesome. It's kind of like multi-jurisdictional, global approach. I really love it, man. This is thinking big, and that's exactly where I want us to be going to. And Egge.
2 words you said? Big dating. My lessons learned from CERN. It's about joining forces, about collaborating, sharing data, and working towards a common goal. And that's what I call big dating. So I hope we'll be doing a lot of big dating in 2040.
Egge, yesterday there was a very interesting webinar organized by Electrolabs, and it was on how to implement remote monitoring devices in your clinical studies. and they drafted a 400-page playbook on how to do that. Do you think, and on all people in the system collaborated on that playbook, do you think that we should start creating a health data playbook?
You can say one word. Yeah, there we go. Good. So we've run out of time, everybody. Clearly, there's a lot more to discuss here. We're only scratching the surface of data in healthcare, even just now, and certainly not looking forward to 2040. So everybody, I'd like to close by thanking all the panelists for giving their time and open insight to this, complex and inspiring topic. It's been a pleasure, an absolute pleasure to have this opportunity to stay with you all. Thanks also to our associates I must mention for a second, Infomet BV, MacT, and AltViz, which we couldn't have done this without you guys. Thanks very much. Our next seminar will be again in around 1 month. Timing will be confirmed shortly. Next time we'll discuss how sensitive data is heavily used currently in highly regulated sectors, other highly regulated sectors such as banking and insurance, what techniques and approaches there can actually carry over to healthcare, for example, what lessons can be learned and borrowed. Follow us on LinkedIn to get the memo about the next new sign-up link is issued. And I look forward to you all joining us with a new panel in around 1 month for the next installment. Finally, thanks to the audience for joining us today, whether you're on Zoom or YouTube. Thank you so much for your questions. I really hope this has inspired you to ask bigger questions and work towards the beautiful future for healthcare together. I hope to see you all again next time, and goodbye for now.